Thank you for joining me for this episode. I'm Dr. David Kading. I'm delighted to be joined by Dr. Kaleb Abbott, and we're going to be speaking about a very, very painful topic, and that is neuropathic pain on the OI show. Here's the tough truth. For every 1 hour we spend with patients, we're stuck doing 2 hours of administrative work, charting, prior authorizations, inbox messaging. And it's not just us. Up to 70% of our team's time is spent on non-clinical work. This isn't why we got into healthcare, and patients feel it too. Many say that they no longer feel truly connected to their providers and the healthcare practices. I've been working with virtual partners for over 10 years, and I can tell you not all virtual staffing companies are created equal. When we found Team, we realized how much better this process could be. Now, we've been working with Team for the last 2 years, and they didn't just find us a name on a resume. They helped us choose the right person, trained them, gave us onboarding system, management tools, and support us to make our virtual team feel like they're really part of our office. Now, our virtual team handles documentation, prior authorizations, billing, patient phone calls, other patient communications, you name it. Our in office team has more energy. Our patients get more face to face time with both my office team as well as me as a provider. And I get to be the kind of doctor that I wanted to be in the first place. If you're ready for a virtual revolution in your office that actually works and you're looking for a partner that helps you do it right, visit hireteam.com. That's hire, HIRETEEM.com. Big thanks to Team for supporting this podcast. Visit hireteam.com. That's hire, HIRETEEM.com. And thank you to Team for supporting this podcast. Well, thank you again for joining us for this episode. I'm excited to have Dr. Kaleb Abbott back on the show. It's good to have you, my man. Thanks for joining me.
Of course, good to be here.
Yeah. So, Dr. Abbott, can you just remind everybody briefly where you're practicing and a little bit about your practice?
Yes, I'm at University of Colorado School of Medicine. I'm an assistant professor there, and I practice exclusively in our dry eye clinic and our Center for Ocular Inflammation. So all day, every day, just treating dry eye and neuropathic pain, which is the
Mm-hmm.
topic of today's discussion.
That's right. So we were discussing somewhat recently just some of the things that we're seeing more often in clinic um, and some of the more challenging cases. And when I go out and do, ocular surface disease lecture, a lot of times I try to focus on the top 90% of what our patients, our practitioner colleagues are seeing. And because I want to turn the faucet down, not just deal with the bathwater. So how do we like turn down the number of people that are getting into the ocular surface disease funnel? And I think we need to be treating far more patients far earlier. Um, and today's topic is going to be the one that we're quite seeing as often, but as you and I were already discussing, it seems like we're seeing it more often than we used to, and that is neuropathic pain. So, can you share just a little bit of what goes into the bucket of neuropathic pain and kind of give us just a little bit of an overview of what it is?
Yeah, I think neuropathic pain is kind of becoming a little bit of a catch-all topic, and it drives a lot of confusion amongst people. But when we're talking about neuropathic ocular pain, we're really discussing patients that have a disproportionate amount of symptoms compared to the amount of ocular surface signs that we're seeing. So, patient
Hmm.
may come in with a little bit of dry eye and a little bit of corneal staining, maybe a slightly reduced tear breakup time, something like that, some MGD, blepharitis, but their symptoms are so much worse than we would expect that their symptoms would be. I think one thing with neuropathic pain that it's important for us to realize is that it's not mutually exclusive with ocular surface disease or dry eye. There's a lot
Right.
of patients out there that actually have a combination of the two. So they have dry eye, but they also have neuropathic pain. So they've got a little bit of dry eye that's driving some symptoms, but their symptoms are again are just so out of proportion with the signs that we're seeing. So we call that more dry eye with neuropathic like features.
Hmm. Yeah. The aspect of it that I think, kind of fits into it, and it seems to be becoming a little bit of a catch-all bucket is the signs don't match the symptoms, right?
Mhm.
And so, as much as you're comfortable, can you talk a little bit about the different types of pain that we're experiencing? Neuropathic pain, nocioplastic pain, nocioreceptive pain,
Mhm.
as you're comfortable, to dig into that a little bit.
Yeah, so when we typically think about dry eye, what we're picturing in our mind is nociceptive pain. We're thinking about all these receptors we have on the ends of our corneal nerves that are firing, that are getting irritated, that's leading to an action potential that's traveling to the brain, that's driving symptoms of discomfort. So an example of that is just pure dry eye. Another example is if you have a nail and you're pushing that nail against the skin. Even if the
Mhm.
nail is not penetrating the skin, it's just poking the skin, that sends signals of pain, through our arm to our brain, that's saying ouch, something is threatening tissue. And that is healthy types of pain. That This is pain that's supposed to be there. It's either telling us that there's damage, there's inflammation, or warning us of damage. But then we have other types of pain too. So the second type of pain is neuropathic pain. This is when we have an injury to the nerve or we're having nerve dysfunction. So examples of this would be like chronic postoperative pain. So patients that get LASIK, that even when their dry eye after LASIK has resolved, they're still having immense amount of pain. That's because we've severed nerves during LASIK and then the nerves didn't grow back properly. Now they have this chronic postoperative pain. Other examples of that, like diabetic neuropathy, when patients come in with pain in their hands and their feet. That's a good example of neuropathic pain. Or herpetic nerve damage. So the patient that still has residual eye pain after maybe a shingles infection of the eye. That's a good example of neuropathic pain. Then there's nociplastic pain, which is the most confusing of all the different types of pain.
Mhm.
This is pain despite no clear tissue damage and no clear nerve damage. What we're talking about here is altered pain processing in the brain. So this is not something that's happening in the nervous system, but really in the brain itself. And this has a lot of overlap with chronic pain syndrome. So when we're talking about nociplastic pain, we're talking about patients that have conditions like fibromyalgia, that have chronic pain syndromes, that might have like traumatic brain injuries. So even after the injury is quote unquote resolved and you can't see evidence of it in an MRI, they still have this residual pain. And even migraines are now considered a form like of nociplastic pain.
Right. There's nothing that we see going
Mhm.
on, and maybe no contributing factors that we can really, blame, like diabetes, uh, or, surgery like LASIK. So,
Yes.
an area where we want to focus on here is it makes sense for the nociceptive that fits with dry eye disease or
Mhm.
ocular surface disease. But within the ocular surface arena of neuropathic pain, what are some of the features that we might specifically see here? And along with that is how do we diagnose? And how do we say, okay, yeah, you have neuropathic pain, and we need to go to another level of treatment here besides just dry eye treatment.
Yeah, so we started off saying the big one. The big one is that the symptoms are out of proportion with the signs. I really don't like the term pain without stain. That
Yeah.
is a pure neuropathic. So there's really no stain at all and they have symptoms. Sure, that's like an obvious neuropathic pain, but a lot of patients again have mixed etiology, a little bit of stain, but severe symptoms. So we're really talking about symptoms that are way out of proportion with signs. Another clue that a patient could have a neuropathic feature of their dry eye is if they have no improvement with standard dry eye therapy. You're trying topical immunomodulators, you're trying high quality artificial tears, serum drops, punctal plugs, various treatments, IPL, and it's not improving. It's possible they have a neuropathic feature. Another way to think about it is sometimes they report their symptoms a little bit differently. So they'll have something called allodynia. Allodynia is pain when there should not be pain. The easiest way to think about this is like photoallodynia. We classically sometimes call it photophobia, but we're talking about patients that say, like, indoor lights kill my eyes. They're not talking about looking at the sun, they're talking about indoor lights causing severe pain for them. We know that indoor lights should not be causing pain in patients like that. So that's pain that shouldn't be causing pain. Therefore, we call it photoallodynia instead of photophobia. Another term that's helpful is hyperalgesia. This is something that should cause a little bit of discomfort causes a lot of discomfort. So, for instance, when we go outside on a cold, windy day, the wind blows in our eyes, it should cause a little bit of discomfort, a little bit of tearing. It's not pleasant. But these patients will say, like, I can't even go outside on a
It's
day that it's
crippling.
cold and
Hmm.
windy because it's crippling. The symptoms are so bad. That's exaggerated symptoms. Then sometimes patients say, like, I've got pain beyond just the eye. Like, they'll say, I've got pain that's radiating up here, that's down here, that's radiating along my temple. I had one patient say yesterday, like, I've got pain here, here, along here, and then to the top of my scalp. And she's literally pointing to the ophthalmic branch of the trigeminal nerve and all the different nerves that are going off that. So that's a sign that there's something further upstream that's happening.
You
If the
know, in
pain,
these, I think one of the things that we observe with these patients is they seem a little crazy. They seem like,
Mhm.
the littlest thing is bugging them so much. And you're like, you must have been, the drama king or drama queen in high school. And it just seems like, and until you fully are understanding the extent of, they're not making it up. Like this is pretty intense for them,
oh
but
yeah.
they come in and they've got their sunglasses on, and you do some sort of pressure test on them, whether it's contact or non-contact, and it just sends them through the roof.
Hmm.
And like probably should be thinking a little bit more empathetically about these people,
Well,
right?
I love that you mentioned that because I used to be terrible at this. I used to think all these patients are malingers, and I just didn't believe them. I said, there's no objective evidence for your eye pain, therefore it can't be real. And then I started practicing at University of Colorado, where we have a confocal microscope, or we used to have one before it broke. So I started using this on a lot of my patients. And I'll never forget the first patient I used this on. And Dr. Scott Hausworth was the one that kind of trained me in this. And this patient came in and she had horrible pain. I mean, she was suicidal, just horrible eye pain, but every dry test we did looked perfectly fine. We imaged her corneal nerves, and she has these things called microneuromas everywhere, like these severed nerves that are full of inflammation that they kind of swell up, and it's highly associated with eye pain. And I saw that and I said, I actually have objective evidence of your pain. And I went through the photos with her. I said, I believe that your pain is real. I'll never forget, she just started bawling hysterically
Hmm.
in the chair. And I was like, what is happening right now? And she said, like, I've been told for so many years that my eye pain's not real. And
Yeah.
and I said, well, no, we have objective evidence that it is real. And just like, hearing that and having someone believe that her pain was real, was so special to her and helped her so much.
Yeah. Well, I don't know if we're going to ever have confocal microscopes across the country. I hope
I
so,
don't think
but
so.
I don't
No,
know.
I
They're
don't think
pretty
so.
pretty expensive. So
They're
the
expensive, yes.
cheaper test that we can do, one of the tests is the proparacaine test, and this is one that we're probably not using as often, but a very simple test for us to do in our dry eye workup with our patients. Walk us through this test and why it works.
This test is so important because I used to not use this test, and I realized I was treating so many patients incorrectly. You use the proparacaine test to try to figure out where the pain is actually coming from. If you've got a patient that's coming in that has a disproportionate amount of pain, you're suspecting that there might be a neuropathic component to their pain. We need to figure out where that pain is coming from because we know you can have centralized pain and you can have peripheral pain. When we're talking about peripheral, we're talking about the corneal nerves. And we know that if the corneal nerves are impacted, we can use eye drops to reach them. But if the corneal nerves are not impacted, you can't reach that pain using an eye drop. So what we do with proparacaine is we tell patients, think about the amount of symptoms that you're having. Maybe it's burning, maybe it's grittiness, maybe it's sharp stabbing pain, maybe it's light sensitivity. And then you don't tell them what you're doing. You just say, I'm going to put a drop in your eyes. We're going to reassess your amount of pain in 2 minutes. So you put proparacaine in the eye. 2 minutes later, you have them reassess their symptoms again. You see, are the symptoms improved? Are they the same? Every once in a while, it's a little bit worse. But so in general, it'll either be the same or it'll improve. And so the patients might say, that I've had a 70% reduction in my burning and a 70% reduction in my light sensitivity. So since we've numbed the corneal nerves, so we know that most of the pain, 70% of the pain in this case, is coming from the corneal nerves, and 30% is coming from something further upstream. So this can help us isolate where the pain origin actually is, which can help us tailor our treatment. Because one thing we see all the time in our dry eye clinic is we get these patients that come in, they say, I've tried Restasis, Cidra, Cequa, Tyrvaya, Triptyr, Mibo, Vivi, all these different things, IPL, plugs, serum drops, nothing's worked. We put numbing drops in the eyes, and then they say, yeah, my pain level is the exact same. So, I mean, we know if you're using an eye drop on something that even a numbing drop isn't going to improve the pain, we know that that treatment's not going to be effective. We're talking about a pain of the eye that is actually happening. The origin is further upstream along the trigeminal nerve. So it helps us get a better idea of what therapies are actually going to work for this patient, what therapies are not going to work.
Yeah, and it tells us how much dry eye treatment
Yes.
resolution we may be able to get, which, I suggest we always get started on the dry eye treatment, but also educate them. This isn't going to solve your, the main pain that you're having, but we
Yes.
want to get started on this. This is the start of it beyond, traditional dry eye ocular surface treatments. What are your thoughts on treatments? How do you go about this, right? How do we treat the pain beyond the central, beyond, how do we get there?
Yeah, so if the patient has a substantial amount of improvement with a numbing drop, that means that the pain is coming from the peripheral nerve. So it's either dry eye or it's peripheral neuropathic. So in that case, we know that topical treatments can reach where the pain is coming from. In general, like let's say you have a post-operative patient, like had PRK and got debilitating eye pain afterwards. In general, we know that the most proven treatment for peripheral neuropathic pain or corneal neuropathic pain is using high concentration serum drops in combination with something to quiet inflammation, like a high concentration topical immunomodulator or even a steroid. And that combination over the course of probably 6 to 12 months can dramatically improve their pain. But it takes time because we're treating the corneal nerves. We're not treating dry eye, we're treating the corneal nerves. So, and the corneal nerves take time to heal, they take time to regenerate. They're a lot slower to regenerate than the epithelial tissue. So, things like serum drops with a topical immunomodulator are helpful. PRP eye drops, platelet rich plasma can be helpful. Scleral lenses essentially reduces that nociceptive pain to zero when you're putting fluid on the eye all day long. Now there is no dry eye. So you're able to just reduce that nociceptive pain, which is sometimes playing a role in these patients. Um, Anecdotally, I've been finding that Triptyr has actually been quite helpful for these patients. We know that tryptamate agonists, which is what Triptyr is, have a known analgesic effect systemically. So there's thoughts that it could help with neuropathic corneal pain. And I had a patient yesterday with debilitating pain that was suicidal after LASIK. She's been suffering for 18 years with this. And she said that she had 75% reduction in her pain after using Triptyr. So it's very possible that that could be a helpful option for patients in the future.
Was that a monotherapy, or did she also do a PRP or some of these other
Well,
things?
yeah, she was already in scleral lenses, Vivi, um, and using high concentration serum drops and still having lots of pain. And then we
Hmm.
added Triptyr, and it was just the addition of Triptyr that led to that big reduction in pain.
That's
Um,
huge. Yep. And then,
and then,
gabapentin and um, Lyrica, those are some that maybe some people aren't as comfortable or know as much about.
yeah, so gabapentin Lyrica I use often for central neuropathic pain, but it does have its role in peripheral neuropathic pain. It does work very well for that, especially like a chronic post-operative pain. So I use gabapentin and Lyrica quite a bit. I start with a baby dose, then I might increase it. These are in general quite safe to prescribe. They're, in my opinion, definitely within optometrist scope of practice to prescribe. I've never had a patient have any complications with it, but you do have to check your state practice guidelines if you're allowed to
When you say
prescribe it.
low dose, what about do you mean?
Mhm. With Lyrica, I will start them off on uh, 50 milligrams once a day at night. So
Hmm.
just in case they get any dizziness or anything like that, then I'll increase it maybe to 2 times a day. When with oral gabapentin, sometimes I'll just start them on just 100 milligrams at night to make sure that they're okay with it. Then increase it to twice a day, then maybe 3 times a day. Sometimes I'll even increase the 100 milligrams to 300 milligrams and do that TID.
Yeah, you
But
increase
one
if the
thing
side effects are not bothering them too much. Yeah.
Exactly. One thing that's super important with this, though, is that we have to treat nociceptive pain prior to neuropathic pain, meaning if there is dry eye, we have to treat the dry eye first. Because even if they have a neuropathic pain, if they're still getting this ongoing nociceptive input, from those corneal nerves being stimulated, they will still be in pain. So the rule of thumb is always treat the dry eye before you treat the neuropathic pain. Get that under
Right.
control first.
So, this isn't a week or a month long treatment. So let's just walk through this. So if I do a proparacaine test, and I'm doing this proparacaine test because this patient is in an overwhelming amount of pain with some dry eye that just doesn't look as severe as maybe it really is. And that patient feels considerably better after we do the proparacaine test. I'm thinking peripheral neuropathic pain, and those patients are needing that added ocular surface treatment that maybe we would say is a more advanced platelet-rich plasma, serum tears, add in immunomodulation, of course, treating their dry eye like we would be treating their MGD and whatnot. There may be some help with some light-based treatments to be helping with nerve pain as well.
Hmm.
And then starting those patients on Triptyr, like you mentioned. Maybe Tyrvaya to be working on the peripheral nervous system a little bit through the
Hmm.
trigeminal nerve. And then oral gabapentin, Lyrica, 50 milligrams, 100 milligrams start up, and then we can increase if the side effects. But what about central? So I do this proparacaine test, and the patient doesn't feel an overwhelming improvement, maybe a little bit, but they still are in a lot of pain. How are your treatments different when that is the case?
Yeah, so these are the hard cases. So, in general, the patient should have a risk factor for some of these. If it's peripheral, they've probably had some sort of trauma, or they've probably had LASIK or PRK or something like that. If it's central, in general, eye pain manifests after systemic pain. So they will probably have other chronic pain syndromes centrally. They'll probably have maybe like a fibromyalgia or a history of
Hmm.
migraines with light sensitivity, or they'll have small fiber neuropathy or something like that. So we have to identify risk factors first. That helps us clue in on what is peripheral and central. So if they're not improving with proparacaine, they have known chronic pain syndrome systemically. What we're really talking about is that their eye pain is a peripheral manifestation of a systemic condition, meaning it's a systemic problem. So it's not going to be reached with eye drops. So we're essentially wasting our time if we do all this aggressive dry eye therapy, unless there is some dry eye. So in general, we're reaching a little bit more for things like gabapentin and Lyrica. I work with pain specialists, and we do a lot of nerve blocks. So they'll do bupivacaine injections along the trigeminal nerve, um, and I've had some home run cases with that, like patients that were suicidal, living in their basement, that were non-functioning, that were able to go back to work as nurse practitioners after having nerve blocks done. Botox can sometimes be helpful. We think it's because it inhibits something called calcitonin gene-related peptide, which we know drives nerve inflammation. So Botox can work well in these cases. We'll usually have that done by a neurologist. Sometimes these patients have referred pain. So the when you look at the course of the trigeminal nerve, it actually goes down to C1 and C2 of the spine. And sometimes patients have tightness around their neck, and that's pushing on the nerve, and that's actually triggering their eye pain. So we call this cervicogenic eye pain or referred eye pain. So they feel eye symptoms despite it being a neck problem. So in those cases, if we're asking about neck pain and things like that, we can end up referring these patients for physical therapy, for things like acupuncture, massage therapy, to get muscle relaxers, things like that, that can really benefit those patients. And then all these patients in general have increased stress and poor sleep, probably some depression, anxiety, trying to control lifestyle factors that we know influences pain perception is also very helpful too.
Yeah, that's huge. And adding in with what you said, for those patients with the photophobia is
Oh
validating
yeah.
them, right? And
Hmm.
validating like this is why. This is, it's not just that you're trying to look like Bono. We really do validate this. And, if appropriate, doing either a spectacle specially tinted lens,
Yeah,
FL41,
exactly.
or, even some of the tinted contact lenses for some of those patients can be helpful. That's something.
Hmm.
So good. This is really, really helpful. Anything we haven't touched on that you think we should, take it home with?
I would say we need to try to do a better job recognizing risk factors for neuropathic pain. We have to start asking patients other questions about what's happening, what's happened in their eye history and surgical history, what's happening with them systemically. So we should try to be screening patients like, do you have fibromyalgia? Do you have a history of migraine, small fiber neuropathy, anxiety, depression? We have to understand as optometrists and ophthalmologists that these things influence pain perception. Therefore, what might be a little bit of dry eye for the average patient that causes a little bit of discomfort, in these cases, all that pain is exacerbated because it is a nervous system problem that is influencing their pain perception systemically and of the eyes. So, we need to do a better job asking patients about associated risk factors for neuropathic like pain
Hmm.
features. Then we also need to try to be using the proparacaine test more often to try to isolate where that pain is coming from and then decide on our treatment options based off this. So we need to just recognize that a lot of our dry eye patients don't just have dry eye, they have dry eye with a neuropathic pain component to it.
Yeah. Yeah. So big, man. Hey, this was a fantastic lecture. I think we hit on every single component. This should be a COPE CE, but sorry, you didn't get it. For all those listening, but hopefully it was helpful clinically for us to dig in. Thank you, Dr. Abbott, for getting through all of this.
Of
And
course.
this was really, really helpful. We appreciate you being on the podcast and sharing with us. Any last thoughts here? I mean, you said we need to be better about it. I think proparacaine test is the big component, unless you have a confocal microscope that's not broken in the corner of your room,
Right.
right?
Right. Yeah, I think the biggest thing I've learned from treating neuropathic pain is that it's actually important to believe our patients. Sometimes, again,
Yeah.
like I used to do, I used to think a lot of these patients were malingers. And then I started to see that objective evidence that no, they really do have eye pain. And
Hmm.
I think it's important to realize this really does dramatically impact their quality of life. So, and we
Yeah.
are in a special place to be able to help these patients out. And so, if you can take someone that's really suffering from eye pain and you can improve that, it really makes a dramatic difference to their lives.
Yeah. Yeah. Totally. Well, awesome. Thank you for being on, my man. Hopefully, we can get you to come back again and share this stuff with us. And thank you for listening to this episode of the OI Show. Make sure to like and subscribe. And please share this episode with a friend and make sure to subscribe. We'll talk to you next time on the OI Show. Myopia management is one of the fastest growing areas in eye care, but it takes the right playbook to make it work. And that's why I work with Treehouse Eyes. They provide the training, ongoing support, marketing, and tools to help independent optometrists succeed. If you're passionate about myopia management, visit growmymyopiapractice.com to learn more.